and Dr. Krishnendu Maiti, our associate professor from IPGMA Calcutta, will be the moderator for the entire session. We are so I request Dr. Krishnendu Maiti to conduct today's program. I will be available as long I'm in the airport and I am not disconnected. Over to Dr. Krishnendu for maintenance of the next of the program.
Thank you, sir. I welcome everybody in this evening online class.
Dr. Ranbir Prasad Singh will join, I believe.
Yes, sir called me
yeah.
a few hours ago, and sir called me that he'll join at 7.
Okay,
So
okay.
we are waiting
That's
for
good.
another 4 to 5
So now you
minutes.
wait for another 5-7 minutes before you start the class. Let few more students join because it's very important topic and it's quite frequently given in the examination. So you have to give some time for the majority of the students to join before you start the class.
We are waiting for 45 minutes.
Okay.
We'll start at 7 o'clock.
Okay. Okay. Thank you.
Thank you, sir.
ঘন্টা লাগবে প্রথমে শুনতে পাচ্ছি না আমার দোষ
It's 7 o'clock. Dr. Krishnendu, you can start your program slowly.
Am I audible, Dr. Maiti?
Yes, yes, audible.
Okay, thank you. The video is not working. We'll have to do without my video.
Okay, no problem.
Okay.
There will be certain problems with these online classes, but the show must go on.
I would request Dr. Ranveer Prasad Singh, President, today's teacher also, to welcome all the faculty, moderators, and the senior consultant, Dr. S.K. Singh, if he is present in the link.
Hello, good evening, everyone. Hello, I'm audible?
Yes, sir, audible.
Yes, sir. Okay. Welcome you all,
दूध का पैसा देना है सुबह का
moderator,
ना
all other teachers, our secretary, and the students.
और वो नहीं ना है क्या बोलते हैं
Today, we
पनीर
are
भी रखे हैं
discuss
कौन सा दूध दीजिए ना वो भी
various studies, but our concentration will be on the psychovaginal
एक ही
fistula.
दे दीजिए
Urinary
एक ही दे
fistula
दीजिए
is part of the kidney itself. Simplest
ठीक रहता है
fistula to
तो कहाँ से मतलब कहाँ से मंगाते हैं
simple psychovaginal fistula.
वो नहीं ना है हाँ कैसे मिलता है वो हाँ?
Please unmute. Please mute yourself. Those who are not in the participants, who are not talking. Yes. Is it all right now?
Yes, sir.
Yes. 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 So we are welcoming you all, the teachers, students, the moderator, and expert, Dr. Sarwan. Hello, Sarwan. Has he joined? Has Sarwan has joined?
पेट उठ नहीं खराब होगा
Yes, yes.
पाउडर नहीं ना है
Without wasting much time, and I hand over the mic to the moderator. So please go ahead.
Thank you, sir. I welcome everyone in this evening online class on behalf of EZUSI. Now, every alternate student will get genitourinary fistula cases in the exam. Usually, it is given in the form of short cases. So, we have prepared this class on basis of a short case presentation. I shall present the salient features. I shall distribute the case to one of the students, and the respective teachers will ask the question to the students. If he cannot give the answer, the question will be asked to the next students. Okay. So we start with our first case. Professor Ranveer Prasad Singh will be the teacher. Sir will ask question to the student. The first student will be Dr. Anurag Misra.
Yes, sir.
Hello.
Yes, sir.
Okay.
Sir.
So, starting with the first case. Is it clear?
Yes, sir.
A 48-year-old female complains of continuous urine leakage 7 days after operation, open hysterectomy for heavy menstrual bleeding. In the operative notes, 3 months before she underwent open hysterectomy. It seems to be uneven. Catheter was removed 2 days after operation. 5 days after removal of the catheter, patient is having continuous urine leakage. She has no normal voiding arch. She is continuously leaking. This is your short case.
What are the things you are finding in the history and what you want to need to know, Anurag?
Sir, good evening. The patient is having a continuous urinary leak for 7 days after basically an open hysterectomy, which was done 3 months back, and the leak was after removal of the catheter. After 2 days of removal of catheter. So basically, she is having a leak, and there is no normal voiding in between. So this is the history. Apart from that, I would like to ask whether this hysterectomy was basically uneventful, or it was prolonged, or there was any bleeding during the procedure or not.
Yes, there was some bleeding, but it was uneventful, and the biopsy report comes to be malignant, non-malignant, benign.
Okay, sir. Yes, sir.
So was it done by gynecologist or the urologist or surgeon? Who has done who is the surgeon or
Gynecologist.
gynecologist? Okay. So what you want more? Any voiding history of the patient? Anything?
Apart from this history, I would like to ask whether she is having any lower urinary tract symptoms, any flank pain, any foul discharge, or a patient is having, if patient have previous history of any pelvic surgery or cesareans or
Patient had history of cesarean section, 2 cesarean sections.
Okay, sir. So, and any, wound essence during those surgeries or not?
No wound lesions. This is 3rd month. Only apart from this urine leakage and continuous leakage, she is not having.
So apart from that, I would like to ask about the comorbidities, if she is having any, or any history of previous abdominal. Yes, sir.
Diabetic and hypertensive. Control on medications, oral medications.
Yes, sir. So that's it. Apart from that, the history of tuberculosis, if there was any in past, especially the abdominal and genitourinary tuberculosis. So that's it, sir.
So you can summarize your patient, that 48-year female with the history of suspected psychoidal fistula with comorbidity, severe surgery of cesarean 2 and hysterectomy, a difficult surgery.
Yes.
And this was the picture before you. So how will proceed now?
Sir, once I receive the patient in the OPD, after the history, I would like to examine the patient. I would first assess her general condition, the pallor and the overall nutritional status of the patient, and then I will do per abdominal examination. I will look for renal angle tenderness, and then I will do a local examination, the per vaginal and per speculum examination.
While examining a lady, what precaution you take?
So I must have a female attendant by my side while examining the patient. I must explain the procedure that I'm going to do the per vaginal examination, and I will basically explain the procedure. How will I do it?
What is the finding, Dr. Mathi? On examination?
On examination, scar mark in the abdomen, lower abdomen, fennel style scar mark. And on genital examination, is continuously dribbling. There is skin excoriation in inner side of the private parts on the inner side of the thigh. And on par speculum examination, par vaginal examination, some induration can be felt. 3 centimeter from the introitus. Is continuously dribbling.
Anything else you like to know?
Sir, regarding the status of the vault, vaginal vault, whether it is closed or open, and the capacity of the vagina, whether it is spacious or not, or what is the depth of the vagina or the length of the vagina, and whether mucosa is, there is signs of inflammation or not.
Yes, the good capacious vagina and signs of some inflammation.
So that's it, sir, in the examination.
Why you are particular about the inflammation, swelling, and all these things? They are important, or just you are asking for the sake of asking?
So, sir, basic first thing is that if the inflammation or signs of inflammation are present, that there, it indicates that the fistula is immature, and second thing, it can be a concurrent infection there. The vaginitis will be there, can be there. So these two things I have to rule out.
So, how will proceed now?
Sir,
Investigations.
in the basically to confer to make a superficial diagnosis, provisional diagnosis, I can go for a dye test in the OPD itself.
Yes, sir, go ahead.
And then, sir, I will do the general blood investigations and go for a CT IVP to rule out, to look for the site and site of the fistula, the number of fistula, and the concurrent uretrovaginal fistula or other associated injuries during the surgery, or any urinoma or collection is there inside or not.
We like to know we want to go for the CT IVU.
Yes, sir.
CTU program. Anything that the upper tract evaluation by simplest ultrasound or anything else? No.
Yes, sir. As an extension of clinical examination, we can go for ultrasound, which will indicate the hydronephrosis and the collection. Along with that, it can give an idea whether the bladder can be, bladder can be distended or not. And yes.
Any clinical test you like to perform in this patient, that whether it is a simply vesicovaginal fistula, retrovaginal fistula, or combined both? Anything
So
in your mind when you see the patient like this?
So we can go for a 3 swab test. We place 3 swabs in the upper vagina, mid vagina, and introitus, and then we make the patient walk and look for which of these swabs are wet. If the upper swab is wet, it is indicative of uretrovaginal fistula. If middle swab is wet, it is vesicovaginal fistula. If lower swab is wet, it could be due to uretrovaginal fistula, or could be by urine soakage. And then we can confirm it with a double dye test.
So these are the clinical tests obsolete, going to be right now in the case of CT IVU. Straight away we go for this. You are talking of the IVU, but clinical tests are important in the ward. People have no time and no patience to do all these things right now. Okay. So the test, Dr. Mathis, what are the investigations done for her? Investigation for this patient.
The hysteroscopy was done, which revealed the 1 centimeter supratrigonal fistula.
That just supratrigonal, just trigone at the end of the trigone, you can call it, and supratrigonal fistula. So would you like to do vaginoscopy also? Anurag?
Yes, sir. So we can add, we can place a guide wire through this fistula or a small or a ureteric catheter, and then we can go for a vaginoscopy to look for the other side of the opening. In the status of vagina.
Any other investigations was done, Dr. Mathis? Hello? 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 Anything other, any other investigations was done for her?
Was done and it revealed bilateral kidneys are splitting, no hydronephrosis, no hydroureter. It is not available here. And there is a contrast spilling in the vagina.
All practical purposes, yes, I have vaginal fistula where you can see the ureteric orifice. You can see the same patient. Is it the same patient, Dr. Mathis?
Yes, sir.
Is it the first case? Next hysteroscopy. This picture is of the same lady.
Same lady. Same lady, same lady.
Same. Number one.
Yes, sir.
So this is very clear case.
Supratrigonal fistula away from the right and left ureteric orifice, supratrigonal fistula, 1:1.
Hemoglobin. Hemoglobin.
Hemoglobin 10.5.
Yes, sir.
How you are planning to proceed this case? Of what is the duration of waiting period for the patient when you go for the planned surgery?
Sir, 3 to 6 months we wait for.
3 months, okay. 6 months in a rare condition, but I think main problem is when idea is there should be no inflammation and edema, and should be nutritionally fit. Cardio, no other morbidity, comorbidity. This is a diabetic, so diabetic should be well controlled. Hemoglobin should be proper, nutritional status should be okay. So, what we are going to do for this lady?
Sir, we have I will proceed with the surgical management of this patient. First of all, I will recatheterize the patient, put on anticholinergics, and then proceed for the surgical management in appropriate time.
Appropriate time. How long she has passed already?
3 months. 3 months. So we can plan for a definitive surgical procedure, but in the during the till the time we are planning, we put the patient on the catheter and anticholinergics.
For this side of fistula, anticholinergic and catheter is a waste of time.
Yes, sir.
Which can
No, sir. This catheter I am placing just to basically to reduce the soakage and the symptoms of the patient. Otherwise, I am planning for definitive management or surgical management, which I would like to go with a trans-abdominal approach because I am well versed, or I have seen that approach only. Otherwise, we have the vaginal, transvaginal options also.
Catheter is not for leakage. The leakage will be there from the vagina as it is happening.
Yes,
But
sir.
from the part that when you go for there, you have to pull the blood towards the bladder neck and you get the area there. So catheterization is done. Not that it will stop the sockets. For this large,
Yes, sir.
not going to stop the. So
Yes.
we have two options. You have the it was with the abdominal root.
Yes, sir.
Am I right? You are
Yes,
well,
sir.
you are well versed. But supra
No, I have seen the abdominal approach, sir.
Okay. So supratrigonal fistula you have seen. So how you proceed for that? There are 3 operations already done for her.
Yes,
So
sir.
what would describe your steps?
Sir, basically, there are multiple options. One is the modified opener procedure, in which I will go with the lower abdominal incision, and then
When you are asked operative step, the position of the patient, position of the surgeon and the light, these 3 things should be described, but in NCH may not be needed, but you have to see the position of the patient. Incision. Finance incision, midline incision. So you have, as you are operating, you are in the one, somebody should even his holding his eye, he can see that what step you need to take.
Sir, it is done under spinal anesthesia or general anesthesia. The patient will be supine, and I go with a lower midline incision.
Okay.
And extraperitoneal. Then after incision and opening the rectus, I will go extravesical.
You need to you go extra peritoneal. Is possible that you can peritoneal? How much are they done? The 2 operations already done. If you have seen the operation, you have
Yes,
done the operation, so you have to be practical.
you can.
In this situation, you have to try to keep this hole, putting gloves and the gauze in the vagina to put obstruct this hole and fill the bladder, so that you are not going to disturb the gut and all, cut anything else. So you have to fill the bladder. This is all other end. It is all contracted. So you have to put some water. Water cannot stay. So you have to try to plug the hole for any means, putting the catheter or putting the Foley's catheter, so and put some water in that so that you can take the suture. So once you reach the bladder, then how will proceed now?
So I will open this anti-cystotomy. Anti-cystotomy is done, and then we absorb the fistula along with the catheter in situ, and then we dissect around the fistula. We'll then we will around taking a margin of 1 centimeter around the fistula, and then we dissect and we close the vaginal end. Then we place the intervening graft flap in between. We can use omentum or we can use a peritoneal flap, and then we close the bladder in 2 layers.
You haven't gone to the back of the bladder and you are going to put the peritoneum or the omentum. You have just made the cystotomy. So you have to go posteriorly where the fistula is there to put this omentum or whatever you want to supplement. You have just opened the bladder and you are dissecting and closing. So where you are going to put the flap, you haven't gone to the posterior side. That's it. You have to go very slow. If you have seen
দুটোই হয়ে যাবে, কোনো অসুবিধা নেই। হ্যাঁ হ্যাঁ, পরপরই হবে, ঠিক আছে, আমার কোনো অসুবিধা নেই।
Precautions we take when we
হ্যাঁ হ্যাঁ,
have this suture material.
Sir, it should be a absorbable suture. Then the two suture lines should not be overlapping, and this should be tension-free, watertight suturing.
Oh, suppose it is large fistula.
Yes, sir.
What we will do for that?
I don't know, sir.
No, you have to buy valve it. Okay, no problem. You have to buy valve up to the fistula, go caudal to the fistula, and we have to one wall of the posterior wall of the bladder will fill the gap. Sometimes you may need to do it. The next cases we will discuss, but you may have to do it to use cystostomy also. So in that small fistula, so it's a clear cut, simple, and without going to posterior, you can't put any peritoneal flap or the mental flap. So simple closure will be there, and watertight and no overlapping. And then how long you keep the catheter?
So for 2 to 3 weeks.
2 to 3 weeks. Any suprapubic diversion or only urethral catheter you like?
Sir, we can place a suprapubic catheter along with a periurethral catheter on both.
What
We can place
yes,
both.
you can use plenty of anticholinergics, drugs,
Yes.
whatever is there. So better you to use it. So sometimes people you have in doubt, you have not the, you can put a suprapubic, but normally good catheter,
One
60
catheter. Yes.
inside, that can happen. How you follow up your case?
So basically, once the patient goes to the ward, we'll mobilize her as early as possible. There will be a we can place a subcutaneous drain also, which can be removed in the post-op day 1. And then, sir, we will start the patient with anticholinergics and the painkillers, and then then patient will be discharged on post-op day 1 or 2, depending on her in progress. And we have to look on the post-op day, on the post-operative day and post-operative day 1. We have to look for periurethral or vaginal leak if there is any. And
Any packing of vagina during post-operative period, packing of the vagina?
yes, sir, we do packing, and that is to be removed on post-op day 1.
Yeah. So this is a simple, case. Okay. Okay, Professor Mathi.
Yes. What? Suppose someone says that I will go for vaginal repair.
Yes, sir.
Someone is expert. Can this be possible in this case?
Yes, sir. Because this is away from the ureteric orifice, vaginal repair can be done, sir. And I think it will be better for this patient because the patient has already have multiple abdominal surgeries, so it could be easy.
So what are the advantages of vaginal repair over abdominal?
The morbidity is less because abdomen is not open. There will not be paralytic ileus. Patient can be discharged early, and there will be less pain. Yes.
What are the disadvantages?
Vaginal shortening will be there, so there could be sexual disturbances later on.
Dyspareunia.
Yes, dyspareunia.
What are the conditions where abdominal approach is the approach of choice, not the vaginal approach?
So if there is a concurrent ureterovaginal fistula or any other fistula like rectovaginal fistula, or we have to go for a ureteric reimplant, or if there is other abdominal surgery planned along with this fistula repair, or if the fistula is very high up and large fistulas, and if the vagina is not spacious, then we can go for abdominal approach. Or if the fistula is due to malignancy or radiation induced, Then also we prefer abdominal approach.
When you are going to remove the catheter?
So generally, after we can keep it for 2 to 3 weeks, and generally most of the people they remove after 2 weeks after doing a dye test to look for any leak or cystogram.
Yes. Thank you. Now we move to our second case. Dr. Kaushik Sarkar will be the teacher in charge, and Dr. Romsu. Dr. Romsu.
Yes, sir.
Thank you, sir.
Yes. Dr. Kaushik Sarkar.
Yes, I can hear you, Dr. Maitri.
Our second case, 31-year-old female complains of continuous urine leakage for the last 2 months. 3 months before, she delivered a dead child. It was obstructed labor for more than 20 hours. First, it was a neglected home delivery. Then she was referred to nearby primary health center. From there, she was again referred to a district hospital. From there to nearby medical college. By then, over 20 hours has lapsed, and the child was dead by that time. And there is continuous leakage from the vagina 15 days after delivery of dead child. There is no normal birthing. So, Dr. Sarkar, please ask the question. Anshu.
Yes,
So
sir.
Yes, Anshu, can you hear me?
Yes, sir.
Yeah. So what is your provisional diagnosis in this case, Anshu?
So this is a case of obstructed labor induced vesicovaginal fistulas.
Okay. How would you proceed to confirm your diagnosis, Anshu?
Sir, I will I would like to examine the patient first. Then first I will do the general survey of the patient about the build, nutrition, height of the patient, and about the stature of the patient, her general condition of the patient. So after that, I will go for local examination. I will examine the abdomen. Then I will do a per vaginal examination, sir, in this patient.
What would you look for in the pervaginal examination?
Sir, I would examine the condition of the vagina, whether any discharge is there from the vagina or not, whether any induration is palpable in the vagina in any of the wall, whether I can palpate the fistulous tract or not, whether the condition of whether the vaginal cavity is roomy or not, or any signs of tenderness in the pouch of Douglas, or any signs of infection. I would also examine any skin excoriation in the vulval region or not, and whether there is any urethral injury associated with it or not. I would also like to do a DRE to confirm whether to rule out whether there is any rectourethral injury, rectovaginal injury or not.
Would you examine the labia?
Yes, sir, I would examine the labia of the patient. If I am proceeding with surgery, the labial pad of fat might be needed for our reconstruction, giving the interpositioning the tissue in between the vagina and the bladders. I would also examine the labia minora. Sometimes labial myocutaneous flap is also given.
Okay. Now, next, how would you confirm your diagnosis?
So I would first do a cystoscopic examination. First I would like to go for a CT eye view of this patient. Sir.
CT eye view was done, which reveals bilateral kidneys skidding normally. There is a vesicovaginal fistula.
Yes, sir. Next, I would proceed for a cystoscopic examination of these patients.
There was urine was dribbling out of the introitus continuously. There is extensive skin excoriation. And cystoscopy urethra appears to be normal, and a big fistula, 3 into 2 centimeter in subtrigonal area near to bladder neck. You can see.
Now, I would like to know the distance of the fistula from both the ureteric orifice and the bladder neck.
Both the ureteric orifice was very close to this ureteric orifice.
Okay.
As it is a big fistula, 3 centimeter fistula, extending from the bladder neck up to the both right and left ureteric orifice.
Okay, sir. And condition of the bladder mucosa and the bladder capacity.
Bladder capacity could not be assessed because it was a very much big fistula. Because it was whatever fluid was given, it was coming out.
Condition of
Bladder
the
mucosa was inflamed.
bladder mucosa was inflamed.
Cystoscopic findings.
So, Anshu, you have a large vesicovaginal fistula, which is subtrigonal, very close to the bladder neck, and both the ureteric orifices very close to the fistula.
Okay, sir.
So, how would you proceed?
Next, I would also like to do a vaginoscopy examination by passing. First, I will pass a guide wire through the fistula and do a vaginoscopy examination. And I would like to assess the distance of the fistula from the introitus.
You can see the guide wire is passed, and vaginoscopy, it was 2.5 centimeter from the introitus.
2.5.
Cystoscopy usually passes from the vagina into the bladder.
Since it is 2.5 centimeter from the introitus, there is a high chance of urethral injury also associated with the fistula. So I would like to see know the urethroscopy status in this patient.
Urethra was normal. No obvious fistula was seen.
Is there any role of doing a micturating cystourethrogram in this particular patient?
No, sir. Since the fistula is very large, the bladder will not hold any dye. And ideally, we do micturating cystourethrogram for a very small fistula, which is not obvious on cystoscopy or IVU. Then during micturation, when the pressure is applied, when the intravesical pressure increases, that time the fistula is revealed in micturating cystourethropy sometimes.
Correct.
But in this patient, the fistula is very large and it's obvious in cystoscopic examination. So I will not do micturating cystourethrogram in this patient.
Very good. So how would you proceed to repair in this patient?
Since there is high chance of ureteric reimplantation or reimplantation, so I would counsel the patient about the abdominal approach of repair in this patient. I will first I will counsel the patient about the chance of failure, about the recurrence of the fistula, and if the patient agrees, then we will proceed with the surgery, sir.
Yes,
And
2 months.
But we have to wait for some more time as the surrounding mucosa near the fistula is inflamed and it's only 2 months. So in obstetric fistula, we should ideally wait for 3 to 6 months so that a demarcation lines appears and all the ischemia which is there to occur and ischemia gets settled. So
What?
approximate time is 3 to 6 months in obstetric fistulas.
So you basically you would like to wait for 1 more month before you repair this fistula.
Yes, sir.
Okay. How in this 1 month, what are the other things that you would like to do to optimize the patient?
So I would advise catheterize the patient and use advise anticholinergics. It will not decrease the it will not heal the fistula, but it will decrease some amount of leakage and decrease the excoriation associated with the fistulas. And advise her to use pads, which will decrease the excoriation associated with the fistulas.
Would you like to do anything about the vagina? Anything to improve the vaginal tissue quality?
So sometimes estrogen creams are advised, but it's not always recommended. So during this time, I can advise estrogen her to apply local estrogen cream, which will increase the vascularity and improve the quality of the vaginal mucosa.
Okay, so we've taken 3 months. 3 months are over. You would be possibly satisfied, Anshu, that it's time to repair the fistula. How would you proceed? What are the different techniques by which you could repair this fistula?
So for repairing the vesicovaginal fistula, we have either vaginal approach or abdominal approach. Vaginal,
In this case, what do you prefer?
in this case, I would prefer abdominal approach, sir, since there is high possibility of ureteric injury during repair of the fistula, and I may need to go for ureteroneocystostomy, sir. So I would counsel for abdominal approach.
So in the preoperative, what should be your counseling?
So I would counsel the patient about the recurrence of fistula.
Recurrence rate in comparison to iatrogenic fistula, whether it is low or high.
So it's high, sir.
Why?
Because this fistula occurs as a result of ischemic necrosis. So
Ischemic necrosis from what?
from the pressure, most likely due to the cephalopelvic disproportion, the head of the baby applies pressure over the pelvic outlets. So due to the pressure necrosis, this fistula has occurred in this patient. And there is high chance of rectal injury, rectovaginal fistula, ureterovaginal fistula, and failure rate is also high. And this since this is a large fistula, so failure rates means recurrence rate are more, and there is a chance of vaginal shortening, dyspareunia, or dyspareunia.
Perineal body injury. Extensive cases.
Yes, in extensive cases, there may be perineal extension of the perineal lacerations and perineal body and rectum, grade 4 injury to the rectum also.
So basic principle of operation.
So first is that the fistula should be adequately exposed, and all the devitalized tissue must be adequately resected. We should do watertight anastomosis, tension-free. We should be able to reach the caudal end of the fistula, and the sutures line should not overlap. Means the sutures line of the repair of bladder mucosa and the vaginal mucosa should not overlap. There should be a well vascularized intervening tissue in this patient, there should be continuous drainage of the bladder, either by perurethral catheter or SPC or both. So,
What would you prefer?
so I would prefer both in this case, SPC and perurethral catheter.
And
There should be tension-free suturing of the anastomosis. There should be tension-free suturing of the mucosa. Ideally, double-layered, watertight closure of the bladder should be there, and their infection should be well controlled before. Infection should be well controlled before the surgery, sir.
And what about the interpositioning tissue?
So there should be a well vascularized interpositioning tissue in this case. I would always prefer to place a well vascularized interpositioning tissue in this case.
What tissue would you use in this case, Dr. Anshu?
So I would prefer omentum as a intervening tissue.
So you would prefer the greater omentum.
Yes, sir.
What is the blood supply of the greater omentum, Dr. Anshu?
Sir, it's from the left epiploic artery and from the greater omental branch of greater omental branch of the right colic artery.
So basically, on which artery would you base your pedicle, the right gastroepiploic or the left gastroepiploic artery?
So I would, in this case, base my pedicle on left gastric epiploic artery. First, I would like to assess the condition of the omentum. Both can be taken, sir.
In practice, both may be used.
Yes, sir.
But
Both can be taken, but if the condition of the momentum is totally healthy, then I would prefer to use the left gastroepiploic artery based flap.
okay. How would you drain the bladder after the surgery?
So I would, so in this case, before during the surgery, I would like to place ureteric catheter. I would in both the ureteric orifice and place a perurethral catheter. And during the surgery, I would do a SPC. All these things will divert my urine and keep the bladder dry. Not means will keep the bladder relaxed, sir. And post-op, I would use anticholinergics.
How and when would you remove the catheters?
So
You have used two catheters. Which one
Yes.
would you remove first?
First, I would remove the perurethral catheter. After 2 to 3 weeks, I would plan a cystogram of this patient. If there is no leak, then I would remove the perurethral catheter first.
So you would remove the perurethral catheter first and then
Yes.
do a cystogram.
Yes, sir. No, I would through the perurethral catheter, I would do a cystogram. If there is no leak, then I
Okay.
would remove the perurethral catheter
And then ask the patient to void with a suprapubic
with the
catheter.
closed clamped suprapubic catheter.
Okay.
There is in other patient obstetric vesicovaginal fistula, there is a urethral loss. How you can manage this?
So if there is urethral loss, then I would have to repair the urethral fistula also. So for that, I would prefer the vaginal approach. Sir, I would in that I would first lift off vaginal flap, expose the urethra, repair the urethra, preferably with BMG graft, and add an intervening tissue, most likely the labial myocutaneous flap or the Marcius flap, and then I would repair the vagina.
See, and so
Yes.
once urethra is involved, must assess the continence of this patient, whether the bladder neck is intact or not. Whatever you do, patient will be incontinent. So once the bladder neck is not proper, is not well preserved, it will, all operation will fail.
Yes.
So we have to take repair again, make, and it is not a job of young people. It has to be must go to the specialist who can construct the
कोई भी
bladder.
दूसरा वाला ले लेना
Yes.
जो नैन प्रो तो लिए थे,
Yes, sir.
उसके अलावा सिमिलेट बोली तो कुछ और एक बार
Angshu, what is the blood supply of the Martius flap?
So Marcius flap is supplied by 3 artery.
और
From the lateral, it's by the obturator artery. From the upper pole, it's supplied by the
इलेक्ट्रोजन लेके देख लो एक बार।
posterior labial branch of the external pudendal artery, and from the inferior, it's supplied by the internal pudendal arteries.
Are all these blood supplies intact during the surgery? Left intact during the surgery? Or
No,
do you
sir.
have
First, I would cut the obturator branch, and depending upon the site of the fistula, either I have to cut one of the polar branches, sir. If I will see that it's easy to place the Marcius flap by cutting the upper branch, then I would do that. Or if it's vice versa, then I would cut the lower flaps, the lower vascularity.
Okay, fine. Shall we go to the next case, Dr. Maiti?
Sir, sir, any question? Or you
Yes.
should?
No. The thing is, in large cases, in such a cases, hello?
Yes, sir.
Yes. The bladder capacity becomes very small and there is an intolerable frequency to this patient. So for some time you wait. Once the bladder is normal, it can regain and patient may be all right. But if it's a contracted bladder, you may need augmentation cystoplasty. So that has to be kept in large fistula, long duration of the neglect. So in such a cases, you may need augmentation cystoplasty.
Yes, sir.
So two things important: bladder neck continence and the size capacity of the fistula, healthy, whether the bladder wall is healthy or not. If it is a contracted bladder, you need. Otherwise, and must consent your patient that you may need CIC. Once you are doing any implant augmentation cystoplasty, patient may not void normally for some time or for a longer period. So this counseling must be done that you may need clean intermittent catheterization for a longer period. These two, otherwise again she will be incontinent. So these things are there before we proceed for these difficult procedures. Okay, please go ahead, sir.
Now we proceed to our next third case. Dr. Kishore. Dr.
Yes,
Kishore.
sir.
Yes. And Dr. Sarkar, Dr. Kaushik Sarkar. Hello.
Yes, I can hear you.
We are proceeding the next case. 56-year-old female complains of continuous urine leakage for last 2 months. No normal voiding arch. In the past, significant past history, she was diagnosed to have carcinoma of the cervix. She received external beam radiotherapy 28 sessions 18 months before. The last 2 months, she is having continuous urine leakage.
Dr. Maiti, did she receive only radiation, no concurrent chemotherapy?
No chemotherapy, only.
Only EBRT. Okay, fine.
Only.
Dr. Kishore,
Yes, sir.
how would you proceed to diagnosis in this case?
Sir, I will first want to know about the present status of the patient.
With
Means,
respect to?
with respect to her more details about the urinary leakage.
She has continuous urinary leakage for the last 2 months. There is no normal voiding urge.
No voiding. Extensive excoriation.
Sir.
General
Sir.
condition is good. Hemoglobin 8.
Any comorbidity, sir? Diabetes, hypertension, or any other comorbidities?
It's both diabetic and hypertension.
So, sir, elderly female with a history of prior radiotherapy for a non-malignancy. As a answer more about, sir, drug history or any previous treatment history or any surgery done for that CS or mix.
No.
The carcinoma cervix was diagnosed by punch biopsy. Was diagnosed by pervaginal biopsy.
Sir,
There is
any
no
planning of
abdominal surgery?
Sir, any planning of surgery?
No surgery. She was having 28 sessions of radiotherapy 1.5 years before. Now she has come with a complaint of continuous leakage and investigations reveal.
There is no, Dr. Kishore, if a patient with carcinoma cervix receives a EBRT, it automatically means that the patient is ruled out as a candidate for surgical extirpation of the malignancy.
Sir. Yes, sir. Sir, then I will first investigate routine investigation like urine routine microscopic and sir ultrasound examination of abdomen pelvis to know the condition of the upper tract first, sir.
Ultrasonography of the abdomen reveals bilateral mild hydronephrosis, and creatinine investigations, creatinine 1.5.
And sir, examination of the per abdomen examinations and the local examination and the post speculum examination of the vaginas.
On examination, urine was revealed from the introitus continuously, skin was excoriated. And
sir, any history of radiation induced abdominal changes like skin condition of abdomen, any genital
skin condition, skin lower part of the abdomen, skin is puckered, and features of inflammations.
And sir, genital area condition of skin, sir?
Yes, vagina is also very tight, and vaginoscopy was a puckered vagina.
And sir, meatus, any meatal narrowing or any condition of meatus?
Stenosis, meatus and urethra was stenosed.
There is atrophic vaginitis and atrophic urethritis in this patient.
Sir. Yes, sir. Then on cystoscopy, sir, urethral stenosis with a big fistula 2 into 2 centimeter in trigone with a ragged unhealthy margin and which bleeds on touch. And sir, both ureteric orifice status, right? Sir?
Right ureteric orifice, very good.
The right orifice is absolutely on the almost on the fistula, and the left orifice is 1 centimeter away.
Sir, as on cystoscopy, it is unhealthy mucosa. Sir, I will wait for sir some more time with conservative management.
Do you expect the fistula to heal with conservative management?
No, sir, the fistula will not heal. But sir, now the mucosa is hyperemic with unhealthy ragged border, sir.
Dr. Kishore, the first thing that we should look for in this patient is what is the condition of her primary malignancy. Sir. Is it under control? So this is something you should be discussing with your oncology colleague.
Sir.
Another thing that you should be doing in this patient is doing a cystoscopy and taking some biopsies from the margin of the fistula to document the disease status.
Sir.
Yes. In this patient, biopsy from the margin, you can see there is margin biopsy was taken and it shows that no recurrence of the tumor. Gynecologist who sent the patient is also have taken the biopsy from the vaginal speculum. There also no recurrence was seen.
Sir. So then I will, sir, plan for surgery, sir.
What surgery, Dr. Kishore?
Sir, I will first in cystoscopy I want to assess the capacity of bladder as it is radiation induced cystatic changes. So in the it may require sir ureteral reimplantation is sir one side is involved and other side is closer to fistula. Sir, I will want to at the same similar setup with augmentation with reimplantation of the both ureters, sir. In abdominal approach mostly, sir.
Okay. How long would you wait for going for the surgery in this patient?
Sir, already it is 1.5 means 18 months passed from the last dose of radiation. So this condition, I think it is matured after 1.5 years, sir. So we can plan for surgery now, sir.
What do you think is the cause of this delayed fistulation?
Sir, it is mostly due to sir radiation-induced changes like obliterative endarteritis and sir radiation-induced necrosis of the tissue, sir.
And how would you counsel the patient?
Sir, counseling about the disease condition as there is already cancer cervix, if the cancer cervix may recur or the repair we are going to do in bladder to control or to treat the fistula, it may recur, it is a unhealthy tissue, or it may require any stage operation like augmentation, cystoplasty, and the need for ureter reimplantation, so complication leading to that operation also, sir.
Dr. Kishore,
Sir.
In case of radiation induced fistula, you have said that endarteritis and all are there. Here,
Sure.
once you go for the closure of fistula, you need some vascular flap to support your anastomosis. No way the simple closure of this fistula is going to heal. It will again cut through and you will have the fistula again. So make the challenging operation, the difficult operation, long time taking operation, and it has to be, in any case, supplemented by surrounding vascular flap,
Sir.
bacillus or whatever you feel that it will work, or you are conversant with that. It should not be taken as a theoretical case. It has a challenging case.
Yes, sir.
Yes.
Dr. Kishore, why sir has told that gracilis flap? What is the advantage of gracilis flap? Over
Sir,
Nectus flap is easily available. Why gracilis flap?
Sir, gracilis flap has, sir, it is a vascularized pedicle flap, and sir, it may use to function like a sphincter. If there is a sphincteric damage, also it is a radiation-induced fistula, maybe bladder, neck, or sphincteric damage. It may function as a sphincteric function, sir. With respect to its watertight or vasculation, it's to increase blood supply or to decrease the to function as a interpositioning flap. It may also function as a sphincteric function, sir, if you used to place it in bladder neck, sir.
Gracilis muscle is out of the radiation field area.
Yes, sir. Yes, sir. Yes, sir.
That is especially in radiation fistula. That is the one of the advantages. And sometimes when you are going for transabdominal approach, just opening the abdomen, you see there is everything is frozen after radiotherapy. You see, in any case, everything is frozen. It's not so easy operation.
Yes, sir.
Suppose you have done extraordinary operation, when will you remove the catheter?
Sir, same with sir other fistula closure. We will, if you are putting ureteric catheter and poly catheter to continuous bladder drain and SPC catheter, sir, after 3 weeks, sir, I will first remove the poly catheter and same. I want to do the dye test or cystogram to look for any leakage, and if there is no leakage, then I will again place the poly and remove the SPC. Then after 7 days, I will remove the poly catheters.
After doing the cystogram, you see there is again leakage from the vagina. What will you do? What are the options? How do
Sir, again, I will place the catheter for another 1 to 2 weeks with anticholinergic. And sir, I will wait for another 1 month, sir.
after 1 month?
Even
still
after 1 month, you see that there is a persistent leakage. What would be your next step?
Sir, it is again, my operation has failed. Sir, I will counsel the patient that we will plan another approach, or we may refer to some hair center, or we may plan another setting of surgery, sir.
There is something that you did not mention, Dr. Kishore, that
Sir.
the counseling during the first surgery. This patient has a treated cervical malignancy treated by radiation.
Sir.
The patient has bilateral upper tract changes. What do you think is the cause of these upper tract changes?
Sir, it due to sir radiation-induced obstructive uropathy, and it may be due. It is mostly due to sir ureteric obstruction, bilateral ureteric obstruction due to cancer cervix, and also due to radiations.
With so many things in mind, with a fistula, with the right orifice on the vesicovaginal fistula, the left orifice just a centimeter away from the fistula, don't you think it would have been more prudent to carry out some other surgery initially?
Yes, sir. At the same time, we should, sir.
What should you have done?
Sir, if there is a ureteric dilatation like mild to moderate hyperrotor nephrosis,
The patient
sir,
has a creatinine of 1.5, as Dr. Maiti mentioned.
Sir, any anatomical dilatation of the ureter, sir, bilateral ureter?
I think you're not getting me, Dr. Kishore. You have a radiated abdomen.
Sir.
Are you here? Can you hear me, Dr. Kishore?
Yes, sir. Yes, sir.
Bilateral, mild to moderate hydronephrosis.
So that wouldn't have been because of the recurrence of the malignancy, possibly radiation-induced strictures.
Yes, sir.
So you have a pelvic ureteric fibrosis in a patient with carcinoma cervix and a vesicovaginal fistula repair. How would you deal with the ureters later on if they developed fibrosis again?
Sir, we'll divert the in our center we are diverting usually in this case. First, we want to put degestenting. If not possible, then we will divert is a bilateral PCN, sir.
Practically, what I would feel, Dr. Kishore, with the clinical information that Dr. Maiti has given us, with a large radiation-induced fistula, with both of the ureteric orifices close to the fistulous margin, especially the right orifice, I think it would have been better to divert the urine of this patient in the first case itself, and in the form of an ileal conduit.
Sir.
What do you feel, Dr. Maiti?
This is diversion of the urine.
What would you what would you have achieved by doing a primary ileal conduit in this patient, Dr. Kishore?
Sir, primary ileal conduit, it's जो main what is the primary जो problem is के जो urinary leakage, it will be controlled. Urinary
Yes.
total is diverted.
What else?
And sir, ureteric obstruction due to radiation, it also get treatment, sir.
Okay, what else?
Sir, in the same sitting, you can sir, plan for hysterectomy, or you can plan the definitive surgery.
Not planning for hysterectomy. This is, when
Yes,
you obviously, Dr. Kishore, you haven't operated on such patients. It's very difficult to get tissue planes in a radiated patient. They are almost impossible to get. So doing an ileal conduit would be bringing the ureters out of the depths of the pelvis into the abdomen. You would have an ileal conduit, a stable renal function. Maybe the creatinine would have come down from 1.5 to a lesser value. Isn't it, Dr. Maiti?
Yes, yes.
And facilitated, see, the treatment of cancer cervix is concurrent chemoradiation, failing which the second line chemotherapies are there. If we had a stable renal function and the patient had a recurrence in the future, she would have been a good candidate for second line chemotherapy even. Now tell me, Dr. Kishore,
Sir,
what type of carcinoma cervix, like which stage of carcinoma cervix patients actually suffer from such a complication?
sir, usually stage 4A, sir, which usually involves sir more central structure like sir urinary bladder and sir bladder neck and sir rectum, sir nearby structure, sir.
Okay.
4A, sir.
You will have your radiation oncology colleagues frequently referring you patients for with carcinoma cervix for pre-therapy cystoscopy. What are the things that you would look for in such cystoscopies?
Sir, first, sir, condition of mucosa and condition of bladder neck and ureteric orifice, sir, bilateral ureteric orifice, sir.
Okay.
Sir, is the ureteric orifice cannula means is that any digestant possible or not? Digestanting is possible or not, sir?
If there is obvious mucosal involvement of the bladder in carcinoma cervix, how is that treated?
Sir, diversion, sir, even diversion, sir.
Obvious bladder involvement, I mean obvious mucosal involvement, not vesicovaginal fistulas.
Sir,
this is here the treatment varies. In obvious mucosal involvement, the patients are usually treated with 2 or 3 cycles of neoadjuvant chemotherapy, which is paclitaxel, carboplatin, and bevacizumab, which is followed by concurrent chemoradiation. The reason being that radiation, radiation-induced fistulas are of 2 types. One is the type of fistulas which develop immediately during the course of radiation therapy. And the second is the one which Dr. Maiti described, which has occurred a long time following the primary radiation therapy. The first type of fistulas usually occur because when there is mucosal involvement by the cervical tumor, radiation causes very rapid shrinkage of the tumor and necrosis of the bladder wall, which is why first chemotherapy is given to these patients, followed by concurrent chemoradiation as before. Just this is the radiation oncologist perspective. You will be having these patients very frequently in your practice.
Yes, sir.
Okay. I think that's it for radiation-induced fistulas, Dr. Maiti. Shall we move on to the next topic?
Professor Singh, sir. Okay, we move to the Singh, sir. Any question to the students?
No, it was routine at CMC Vellore that every patient of the radiation CA cervix was used to send to urology OPD for the cystoscopy. But our previous teachers said that is very essential that any patient CA cervix, there will be coordination between the urologist and the oncology department so that they can have the first hand cystoscopy picture and his diagram with him. And for future follow-up, it's very good. So each and every month we used to spend 20 cases for the cystoscopy from the oncology department. That was a routine there. And this problem of diversion in such a cases is very tedious also. And once creatinine level is raised, all the electrolyte changes are very frequent in that cases. So whatever the patient, bilateral PCN is also troublesome, and this ileal conduit is also troublesome in 1.5. So these are the things which we have to balance, how the patient fares. And I think both way we can go. Sometimes it's a on cases, then we have to plug the ureter permanently and put the patient on the bilateral nephrostomy. So that is all terminal cases, but everything has to be weighed. Only diversion is not better. If it not have been the otherwise radiation cases, then men's pouch for this poor patient is a very good option. Men's pouch 2.
Men's pouch 2. Okay.
Yes. So that's a very good option. So I think that all things has to be balanced in the perspective of the doctor present there and his patient. It's not that we can guide from here to the doctor that if we like that. It is exam oriented, so the student must know everything, and for that we are discussing the things.
Thank you, Dr. Singh. That was very interesting.
Thank you, sir. Now we move to our next discussion, that is question answer about the BVF repair, abdominal approach and vaginal approach. Sir, sir, please.
Hello.
Yes. Dr. Amit Ranjan.
Good evening, sir. I'm Dr. Amit Ranjan, sir.
Singh, sir.
Yes.
GMCH Guwahati.
It is the operative session, abdominal approach and vaginal approach. I think we have discussed the abdominal approach. We start first, discuss about the BVF repair vaginal approach.
So you are asking me to proceed?
Yes, sir. Yes, sir. Proceed.
Okay.
Dr. Amit will respond to you.
Yes. Hello.
Yes, sir. Good evening, sir. I'm Dr.
Good
Amit
evening.
from
Yes, Amit, yes, Amit, yes.
Yes, sir. GMCH Guwahati, sir.
Okay. I was just in Guwahati last week. I was in Guwahati only. Huh?
Yes, sir.
Yes. So, what are the indications that you opt for the vaginal repair of the VVF?
Sir, in any urogenital fistula, we can do repair from the vaginal route, sir. However, it is more preferred to do in the low-lying, small size, simple vaginal fistula, sir. From the vaginal route, sir.
So, have you seen, done, or assisted the vaginal?
Yes, sir. I have seen, sir, and assisted also, sir.
Assisted also. So, what is the position of your patient?
Sir, generally, sir, we are putting the patient in the lithotomy position, sir.
Not jackknife.
Sir, low lithotomy position, sir.
Low lithotomy, not the jack on the abdomen.
No, sir.
No.
Jackknife generally we are not doing.
Not doing. Okay.
Yes, sir.
So proceed for the steps.
Yes, sir. Sir, after putting the patient into the lithotomy, sir, we used to do the wash and wrap the patient, and after that we are doing the cystoscopy, sir. and urethrocytoscopy. And in that case, sir, we used to see the whole of the urethra and the bladder, sir. And we try to find out the site of the fistula, number of the fistula, and location, and with the relation of the fistula with the ureteric opening, sir. And after that, sir, we used to give the two different color ureteric catheterization in both right and left ureteric opening, sir. And after the finding out the sir, fistula, we used to cannulate that fistula also with the Foley's catheters after on the guide wire, sir.
Excuse me, somebody should mute those who are not participating. The student is talking, so please mute yourself, sir. Okay, go ahead.
Sir, after giving the catheter through the vagina, sir, and over the guide wire, sir, we we start the looking the vagina with the Sims speculum and anterior vaginal wall retractor, sir. And after seeing the site, and we used to mark the sir, fistula, and we after that, sir, we used to do generally a Latsko procedure here, sir. And we generally doing a circumferential incision over the periphery about 0.5 to 1 centimeter peripheral to the catheter, and we used to dissect the plane between the urethra and vaginal wall, sir, anterior vaginal wall. And after that, sir, we used to trim the we used to fresh the fistular margin, sir, and we close the fistula with the vital, sir. And after that, we used to do the give the generally we are using yes a Marcius flap, Marcius fat pad, sir. And after that we will put there, and we used to close the vaginal wall and then over the vaginal flap, sir. And after that, sir, sir, sorry, I have forgot, sir. We used to keep the SPC also while doing the cystoscopy, sir. And after the giving the closure of the vaginal flaps, sir, we used to put the vaginal pack for 1 day, at least 24 hours, sir.
You take the biopsy. What are the situations? You take the biopsy from the margin of the fistula. Second, once you close the vaginal, bladder mucosa, you check the competence of your closure, whether it is watertight really or not, or you
Yes,
proceed
sir.
as such.
No, sir, we used to see the patency also, sir, with the methylene blue, sir.
So you see the water tightness, whether closure is perfect or not.
Yes, sir.
Anything more? When you remove the ureteric catheter?
Sir, generally, sir, we used to keep the Foley's catheter for at least 2 to 3 weeks, sir. After 21 days, we generally doing the cystogram, and after that we used to remove the Foley's catheter and clamp the SPC, sir. And after let the patient to wash do the pass the urine for, and if she will be comfortable with the passing urine for at least 2 to 3 days, then we can remove the SPC also, sir.
Have you encountered recurrent fistula?
Yes, sir, I have encountered, sir.
What was the problem with, what was the reason for this recurrence and how you managed it?
Sir, actually, sir, patient was, sir, the cause generally was the sir, the post removal of the Foley's catheter, patient was fine, but after 2 to 3 days, sir, there was again the leak was there, sir. That's why we have again given the catheter for one more month, and after then again we have followed up the patient. The patient has again that there was leak, sir. So we have things.
What do you think? What are the thing in your mind? What are the point in your mind that the reasons for recurrence of the fistula or the failure of the fistula closure?
Sir, mostly it may be infection at the operative site, sir.
Infection is there, that is their infection, anemia, but the
Yes, sir.
tuberculosis, malignancy,
Yes,
and the missed fistula, there are double fistula, the Y-shaped fistula, and something
Yes.
like that which we have missed during the closure. We haven't
Yes.
made it one. So these are the situations which one must take care of and
Yes.
must take the biopsy in case of at least the recurrence of the fistula or the failure in the first attempt. So that has to be done.
Yes, sir.
And they need antituberculous treatment or the if it's malignancy. So failure of the fistula closure, the surgical failure is one part. And the other points are there that has to be kept in mind to the surgeon. Thank you very much.
Thank you, sir.
Mathi Saab, sir. Moderator, sir, please.
Yes, sir. Thank you, sir. Dr. Ami,
Yes,
when
sir.
you are doing vaginal approach of repair of the VBA,
Yes, sir.
mandatory to put SPC.
Sir, in our institution, it's a institutional protocol, sir. But some people are saying, so it's a controversial also. Some people doesn't want to put the SPC, but we are comfortable with this, and the result will also fine, sir. That's why, sir. If there is a block or anything, sir, we can. If there is any clot or anything blocked, sir, we can. It will help, sir. That's why we are keeping this.
And for first time vaginal repair,
Yes, sir.
margin refastening and fistula tract excision.
Yes, sir.
Required in every cases.
Sir, first time generally, sir, we do not used to do the Webster type, sir. Generally, we are doing the this one, sir. Let's go only, sir. We just refresh the margin and we used to close. Sir.
What is the role of estrogen cream?
Sir, we are giving, but the role is controversial, sir.
Postmenopausal women you can give when there is specific
Yes,
evidence of
vaginal atrophy.
And when the vagina is capacity is not so much, what
Yes,
extra thing you do?
So if the vaginal capacity is not good, sir, then we used to do the transabdominal approach, sir, to the spacious, not spacious, long and tubular vagina. So in that case, sir, we used to do the transabdominal approach. O'Connor, sir.
Okay.
Guy, mama.
Now we move to our next operative session, that is the abdominal approach of repair. Hello, Dr. Kaushik Sarkar. Dr. Kaushik. Dr. Onsu Kumar from the students.
Yes, sir.
So, what is the basic principle of abdominal repair of the VBA?
Sir, the basic principles.
Most of it has been described already. Just the basic principle.
So the basic principles are adequate exposure of the fistulous tract, we have to expose up to the caudal part of the fistula. There should be a tension-free repair, watertight closure of the bladder, and the bladder should be well drained. Before repairing, the infection should be well controlled. The suture line should not lie in the same line, and there should be a well vascularized flap to interpose between the bladder and the vagina.
What is the transvesical approach?
So it's also known as Gilbert approach. In that, we need not bivalve the bladder. We go.
What is the procedure of bivalving this bladder?
So it's a O corner.
O corner.
Yes, sir. So in O corner we bivalve bladder, but in Gilbert approach we just stay in the space of ridges, means extraperitoneally. We open the bladder, just go transvesically, dissect the fistula tract, remove the fistula, and close the bladder and the vagina in layers with interposition of omental or peritoneal flap.
What are the advantages and disadvantages?
So advantages are that if we need not bivalve the if we bivalve the bladder, then there is a chance of urgency and urge incontinence in the post-operative period. So it's avoided, and less the incision is smaller, and if urinoma occurs in post-operative period, then it do not get urinoma. If leakage occur in the post-operative period, urine do not get collect in the abdomen.
What is the success rate of your transabdominal approach?
So it's at par with the vaginal approach. Sir. Means both have almost equal success rate.
What in figure? Is it 100% vaginal fistula repair? Because this is important while counseling the patient.
No, sir. The success rate is only 85%, 85 to 90%.
Is it different in open or laparoscopy?
No, sir. It's almost same in both the procedure, open and laparoscopy.
So what are the advantages of laparoscopy?
So the incision is smaller, less hospital stay, it's less morbid to the patient, less post-operative pain, the patient can be discharged earlier, and so these are the advantages, and disadvantages are it is technically more demanding, suturing is little bit difficult, and it's difficult to go caudal to the fistula in laparoscopies.
Singh sir.
Yes, sir.
Any question, sir?
What is the success rate for vesicovaginal fistulas post radiation therapy, Dr. Anshu?
It's almost 55 to 60%.
No, it's slightly more than that. It's almost 66% actually.
when you need for the reimplantation
Yes, yes.
and the capacity is small. So what are the things you do for that patient? Reimplantation, you need to reimplant the very close to the very large fistula, and ureteric orifice is very close to the fistula.
Yes, sir. If the bladder capacity is small, then we need to augment the bladder, sir.
True.
In case of radiation cystitis, if the capacity is small, what is the ideal material for augmentation? And in case of other cases, what is the ideal material for augmentation? Is there any difference?
Yes, sir. In radiation cystitis, the colons, the sigmoid colons are well exposed to the radiation field. So we will prefer the upper part of gut, that is jejunal segment, or the ileum, proximal part of ileum segments.
In large fistula, whatever I wanted to know that we need only one ureteric transplant implantation. Others you can just move the bladder itself wall and close the fistula. It will fill the gap. And you don't need to bilateral ureteric implantation in most of the time. Only one side implantation, you will save your time. So you can leave it there and you can move the one half of the bladder towards the opposite side and suture it into 2 layers as you suture the bladder, and one side the ureteric implantation. It will save your time. Bilateral ureteric implantation will take a lot of time. So that method, that practice you can apply and save your time.
Yes.
Yes.
Okay, sir. We next proceed to our next clinical scenario. Dr. Anurag. Dr. Anurag. Dr. Anurag.
Anurag Mishra.
Yes, Dr. Anurag Mishra. We have lost contact with Dr. Anurag Mishra. So, Dr. Kishore Behra. Dr. Kishore. Hello.
Yes, sir.
Dr. Kishore.
Yes, sir.
You are available?
Yeah, sir, I'm available.
Dr. Kaushik Sarkar.
Yes, I'm there.
We pass to our next case. A 48-year-old female complains of continuous urine leakage 7 days after lap hysterectomy.
Yes, sir.
The operative history: patient had menorrhagia, for which she consulted gynecologist, and after investigations, lap hysterectomy was advised. It was done 2 months before. There was some difficulty because of bleeding, but the operation could be done, and catheter was removed as per protocol on the 2nd post-operative day. Patient was all right for next 6 days, but 8 post-operative days, suddenly patient is having continuous urine leakage, but still she is having normal voiding urge and she can void also. But there is continuous urine leakage that bothers her, and she has come with this complaint. Dr. Kaushik Sarkar, you please.
Okay. Just who is the student here right now?
Yes, sir. Dr. Kishore, sir.
Dr. Kishore, I can't see you actually. That's right. Okay. So, Dr. Kishore,
Yes,
what is your provisional diagnosis in this patient?
sir. It is followed by a hysterectomy with a prolonged surgery. Sir, I think there may be ligation or ligation of artery, uterine artery, leading to ligation of one side of ureter during the surgery, sir. And that lead to, sir, ischemia and formation of the fistula, sir.
What other operational history would you desire from this patient?
Sir, cause of the prolonged bleeding, sir.
Cause of the
Prolonged bleeding, prolonged operations.
Patient, the operation was total to 1.5 hours, just more than that. There is some difficulty with the bleeding during the operation.
Sir, inadvertently, there's a tired, sir, uterine artery, which is just anterior to the lower end of ureter, sir.
Would you not like to know the histopathology report of the hysterectomy specimen?
Yes, sir. What is the cause of the hysterectomy, sir?
Menorrhagia was the cause, and the postoperative histopathology is a myoma.
Yes, sir.
Myoma.
Okay, so that rules out a malignancy. And
Yes, sir.
so how would you proceed for diagnosis in this patient?
Sir, I want to examine the patient, sir. Is there any general examination with general condition of the patient with anemia and any signs of infections? And sir, local examination looking for meatus and condition of vagina. And sir, post speculum examination to see for any induction or any know the fistula, sir, opening, sir. Fistulas opening into the vagina, sir.
Anything else in the physical examination?
And sir, any flank tenderness, any, sir, any swelling in abdomen, to is there any obstructive changes in the kidney, sir?
Okay, that's good.
2 months after operation, there was no abdominal tenderness, and on examination, urine was dribbling out of the introitus. There was some skin excoriation, and vaginoscopy reveals continuous. Vaginal examination reveals continuous urine leakage. No induration can be felt.
Yes, sir.
Yes.
Sir, then I would, sir, want to do, sir, ultrasound examination and routine investigation like renal function test and CBC and sir, normal hemogram, sir.
Hemoglobin
What
8.
would you want to get from the ultrasonography, Dr. Kishore?
Sir, I want to know the which side ureter is in dilation in the upper obstructive changes, sir. So any dilatation in the pelvic calyceal system of which side, sir?
On the ultrasonography, left, there is moderate hydronephrosis and hydroureter. Left
Sir,
side,
urea creatinine, sir, RFT status of the patient, sir, renal function test, sir.
Okay.
urea 28, 18.9.
Is there any abdominal urinoma or any, sir, pelvic urinoma, sir?
No collection.
So what is the next investigation that would you do after the ultrasound?
And sir, I want to know, sir, post speculum and cystoscopy examination in one sitting, sir.
Wouldn't you like to do a CT IVU in this patient, Dr. Kishore?
Yes, sir, CT IBP first, and sir, with that, sir, I want to with sir, CT IBP, sir, first with 60 cystogram, sir.
Yes. We would do a CT whole abdomen with a CT IV with CT IVU images before we would proceed for any surgical planning.
Yes, sir.
So on cystoscopy, we find the urethra to be normal and the bladder to be normal, no fistula seen in the urinary bladder. So what is the next thing that you would do?
Sir, I want to source the fistulas opening in the vagina by post speculum examination or vaginoscopy, sir.
Before that, wouldn't you like to cannulate the ureters?
Yes, sir. Cannulate the ureters, sir.
That should be mentioned first, isn't it, Dr. Kishore?
Sir.
You have a patient who is leaking continuously and also has a normal pattern of voiding. So the first diagnosis would possibly be a ureterovaginal fistula, which you have possibly excluded by a
cannulation, sir.
You excluded a vesicovaginal fistula by a cystoscopy examination. So the next thing would be a cystoscopic examination and a retrograde pyelography of the affected ureter. You know the site of the pathology. isn't it,
Yes, sir.
Dr. Kishore?
Yes, sir. Yes, sir.
So what would you do by cannulating the ureters?
And sir, for RG retrograde pyelogram, I want to after cystoscopy, I want to cannulate or put my ureteric catheter the ureteric orifice. Then I want to inject contrast medium like sodium ditrogate or urographene dye. And sir, on fluoroscopy on with fluoroscopy guidance, I want to locate the site of leakage, sir.
Okay.
In this patient, RGP was done on the left side. After initial 1 centimeter, contrast cannot proceed with the contrast. There is complete cutoff after initial 1.5 centimeter.
Yes, sir. So it is a means it is a case of ureter of vaginal fistula on the left side, sir.
So how would you proceed next, Dr. Kishore?
Sir, I will first counsel the patient. I will plan for surgery, sir. As already, sir, 3 months passed, and sir, I will want to proceed for the surgery of the ureter vaginal fistula, sir.
What is the timing of repair for ureterovaginal fistula?
Sir, if it is identified just intra-op or on table call, and we identify just a fresh injury to ureter, which if it is diagnosable, so we repair it primarily over a stent. If not, then after 3 months, sir. Sir, window period is 3 days to 3 months, sir.
Okay, what are the different techniques of routes by which reimplantation may be done?
Sir, mostly, sir, a trans-abdominal route, maybe, sir, open method, or maybe, sir, laparoscopic or robotic method, sir.
Okay.
Sir.
Suppose in this patient, a retrograde pyelography revealed extensive ischemic damage to the right ureter, to the affected ureter by diathermy, with the damage extending to the upper level of the sacroiliac joint. How would you have gone ahead?
Sir, it is sir, my primary reimplantation is not usually not will be difficult. So I want to use the sir advantage of technique like sir swash stitch or sir. I will first want to estimate distance between the ureteric bladder wall and my healthy ureter. So if it is around 10 to 15 centimeter, I will proceed for sir Boary flap, sir.
Okay. Now, Dr. Kishore, Dr. Maiti, can we please go back to the initial slide for this patient?
Yes.
Now, this patient basically has come with a continuous urinary leakage 7 days after the surgery, and the history of laparoscopic hysterectomy was done 2 months before. Now, suppose this patient 2 months before. Now, suppose you have a different scenario in which the patient has undergone a laparoscopic hysterectomy and develops urinary leakage in the immediate post-op period associated with fever and flank pain. How would you approach this patient?
Sir, if it is acute obstruction to the suspected side, sir, first I will, sir, if patient is in septicemia or any acute pain, so I will divert the urine by putting an nephrostogram of that side, sir.
Wouldn't you like to do some imaging before you proceed for the surgery?
Ultrasound, sir. Ultrasound and CBC, sir. Clinical tenderness and the CBC and ultrasound. Sir.
Wouldn't you like to do a CT scan? I mean, for a pelvic structure like the ureter and such a complicated pelvic, when you are suspecting a ureteric injury, wouldn't a CT scan upfront be a better investigation?
Sir, CT scan is needed, but a patient is in severe tenderness. If CT scan available is usually done, it's okay. But if it is not possible to done, so we may proceed with PCN with ultrasound guidance.
Is there anything else that we might attempt in this patient?
Yes, sir.
Dr. Kishore, CT scan is now readily available in all parts of the country. So I believe before venturing into such a patient who develops flank pain, fever, and abdominal tenderness, possibly a CT scan would better serve the patient. would also help you to rule out any other adjacent organ injury, like maybe the rectum or the colon.
Yes, sir.
See, now percutaneous nephrostomy, Dr. Kishore, it involves you do an ultrasound guided PCN. The patient has a tube coming out of the flank.
Yes, sir.
Would you not attempt a cystoscopy or RGP and a primary stenting of the injury if possible? Before
Sir,
doing a percutaneous nephrostomy?
Sir, if it is completely, sir, not obstructed, sir, it may be possible to attempt CP and RGP and digestion. Sir,
So
as the
that should,
patient,
so that should be attempted first, Dr. Kishore. If a patient has a ureteric injury, a suspected ureteric injury, which you have diagnosed by a postoperative CT scan, a cystoscopy and RGP and an attempt at stenting, I think that would be in order, because just think of yourself, think about the patient. What would be
Yes,
more
sir.
easier for the patient to handle? Would it be a percutaneous nephrostomy sticking out of the flank or a internalized DJ stent?
Yes, sir, both sir possible.
No, what would you prefer for the patient? What would be more comfortable for the patient, Dr. Kishore?
Sir, stenting, sir, internal stenting more better comfortable for patient than external stents.
And
External
prolonged
patients.
catheterization. A
Yes,
DJ
sir.
stenting followed by prolonged catheterization.
Yes, sir. Yes.
Suppose you got lucky, you were able to stent the patient and you put in a catheter. After how many days would you remove the catheter?
Sir, actually, if there is no vesicovaginal, is there any no extra fistula rather than partial injury to ureter, sir, we may remove the catheter after, sir, 2 to 3 weeks, sir.
And suppose the leak stops after that, the patient is fine. How would you counsel the patient? What would you tell him? What would you tell the patient? What would you tell her?
Sir, we will then, sir, remove the digestion after 6 weeks, sir, and with counseling that the injury which might occur may be healed with prolonged drainage, sir.
I would possibly advocate a longer stent period. Wouldn't it, Dr. Maiti?
6 weeks in the Campbell it is said that 6 weeks is good enough, but after removal of the stent you have to go for further investigations.
You have to follow up the patient very carefully. You have to counsel the patient that the stenting might solve the problem temporarily, but it might lead to a stricture in the long term. Can you hear me?
Yes, sir. Yes, sir.
So how
The
do
patient,
follow up the patient?
the patient may still develop stricture later on and might require a ureteric reimplantation following that. Extremely close follow-up is very important, Dr. Kishore, because even after successful stenting, the patient might develop a ureteric stricture which might result in loss of function of the affected kidney. Extremely close follow-up. Immediately after removal of the stent, you should counsel the patient for close follow-up, possibly initially with the help of ultrasound, followed by a CT scan if required.
Yes, sir.
Okay, then. Over to you, Dr. Maiti.
Sir, Singh sir, any questions?
Yes, there are two things I like to add. That one, in ureterovaginal fistula and this vesicovaginal fistula may coexist. So once you diagnose even this clear-cut ureterovaginal fistula, please have a CTI view and look for the concomitant vesicovaginal fistula too, and repairs would be done of the both together. As far as pure ureterovaginal fistula is concerned, there's no need to wait for 3 months time. You have the healthy ureter and cut the ureter, you get the healthy end. You cut the bladder where you want to implant, do the uterine cystostomy, that is healthy. For 3 months waiting period is the area where there is infected, the edematous, there is inflammation, that has to subside before you go for the repair process. So pure ureterovaginal fistula, you don't need to wait for a such longer time. You have the clear cut and healthy margin both the end. But hemoglobin level and the nutrition would be better for the patient. So these two things I have read, and otherwise the discussion was very fine. Well done.
What is the success rate, Dr. Kishore?
Sir,
Success rate of this operation?
sir, urinary reimplantation, sir.
Yes, uterine implantation. What is the success rate in comparison to the other VPA or other fistula surgery? Better or worse?
So 90%, sir.
Pardon?
85 to 90%, sir.
Whether it is results are better in comparison to VVF or worse?
Sir, usually it is associated with VBF. There is a, I don't know, sir, there is isolated.
What percentage of the cases ureterovaginal fistula is associated with the VVF? Or rather, VVF associated with the 10 to 12%.
12%, sir.
Isolated cases of ureterovaginal fistula. Success of the repair, whether it is good in comparison to VPF or it is worse. Probably it is good. Okay. Now we proceed to our last case. Singh sir. Hello.
Yes, yes, please, sir.
Dr. Anurag Misso, is he available? Okay. Dr. Amit,
Yes, sir. Good evening, sir.
go to the last case. There is a 48-year-old female complains of urine leakage 15 days. And there is a history of TVT operation for stress incontinence 6 months before. The patient was doing well, but for the last 15 days, she complains of urine leakage from the vagina when bladder is full. And otherwise, she is having more or less normal voiding. But when the bladder is full, she complains of some urine leakage.
Yes, Anurag.
Sir, I'm Amit, sir.
Sorry.
Yes, sir. Sir, I'd like to ask something, sir, about the history, sir. Whether why the TVT has been done and what during
Stress urinary incontinence for that reason.
and during operation period and post-operative period, was there any infection or any complication was there?
There was some infection in the vaginal mucosa, but that was dealt with antibiotic.
Yes, sir. And was there associated with LUTS or anything like that, sir? Or urosepsis?
Occasional dysuria, urine culture, E. coli, that was sensitive to nitrofurantoin and ofloxacin.
Yes, sir. Primary menace, sir. And no associated sir, trauma, history of trauma, any cross injury, blunt injury, nothing is like that, sir, in the past.
For the last 15 days, she is having occasional dysuria, urine culture reveals some infection and urine leakage. That too, not very extensive urine leakage, but she complains that when the bladder is full, she cannot hold some urine that is coming out.
Is the sir leak was associated with the change in the posture, sir, the patient?
Yes, patient when sitting, it was not leaking. When from sitting to standing and especially in the full bladder and coughing, it was a leak.
Yes, sir. So, sir, my provisional diagnosis is it is a ureterovaginal fistula, most probably, sir, or associated vesicovaginal fistula along with it, sir. Post TVT operation, sir.
Singh sir, please.
Yes. What is the status of the penis what are the investigations done before the TVT operation for that patient?
Ultrasonography, which reveals no residual urine, uroflowmetry was done, and patient is having clinical history of stress urinary incontinence, and the operation was done by some gynecologist.
It was pure stress incontinence or combined with the urge or
Patient has mixed urinary incontinence. She was given anticholinergic. She partially responded, but had frequent symptoms. That's why she underwent TVT.
the problem is if you have any mixed incontinence, urodynamic studies should have done. Should be done before that we proceed for this TVT or any surgical procedures.
Yes,
So
yes,
now
yes.
we have been fined. Now the fine is to the surgeon and the patient both. So we must go for yes, proceed, Kishore.
Sir, I'm Amit, sir.
Sorry. Yes.
Sir, patient, as sir has told that patient has a history of urinary infection. So I'll want to go for again the urinary examination with the urine routine microscopy and urine culture. And along with that, sir, I want to do the ultrasound of the kidney, urinary, and ureter and bladder, sir. And if there is no any infection and no hydroureteronephrosis, sir, in that case, sir.
Patient has no hydroureteronephrosis.
Okay,
Post-birth residual was 60 ml.
Yes, sir. Sir, sir, after that, sir, I want to go for some investigation, sir. I want to do, sir, two investigations. One is the, sir, urethocystoscopy under anesthesia, sir, so that we can find out the site or size of the leak or any rent, sir.
On examination, urine dribble when the bladder is distended, there is minimum skin excoriation. And cystoscopy, bladder was normal, no fistula seen. And on after very minute examination of the urethoscopy reveals a suspected fistula.
Over, sir.
Close to just distal to sphincter.
Sphincter, sir. Sir, I also want to do, sir, video urodynamic in this case, sir. If,
no, get first CT.
Yes, sir. CT
histogram and with the CT histogram or CT histogram you can get it.
Yes, sir.
So what does it show?
Sir, my diagnosis is if there is after the, sir, urodynamics, sir, I can say that it's a case of a urethrovaginal fistula, or along with the urethrovaginal fistula, it's a component of the baby. Sorry, SUI is there or not, sir?
Urodynamics problem may help you sometime, but the cystogram will be definitely there to be smallest leak with the methylene blue or something. With the contrast, you can see that the side of the fistula when the patient stands. So you can find it out.
Sir, anatomical and sir, sphincteric. Actually, because I want to know the sphincteric condition, sphincter condition in this patient, sir.
Yeah.
That's why.
It is widening well.
Yes.
Widening well. That's the why sphincter problem is widening well. There's only problem when she stands up. So
yes.
Positional. The fistula in such a site that it there is a sort of pouch type thing where there is a fistula and it urine leakage from there. So you must have a good anatomical as well as functional status of that. Okay,
sir, Sir, as it has told that the fistula is present just distal to sphincter, sir.
Yeah,
So, there should not be any leak, sir, in this case. But if there is a leak, sir, that's why I want to know some other, if there's any other component along with it, sir.
In this case, the leak was not so significant, especially when she sits only when stands with a full bladder, there is some leak.
Yes, sir. There is a most urethrovaginal fistula, sir.
this is the problem in the case that the pre-operative, all the investigations, cystogram and the urodynamics should be there. So there will be no problem right now in diagnosing and treating the case. Now what has happened, we are in the blind dark spot. Some other surgeon has done and the record is not with you. So this fistula, we have to go for cystoscopy and anticholinergics and all conservative therapy. You have to treat the urodynamics and cystogram. You have to treat all conservative manners. If it fails, then we can have to go for the surgical if needed. I think that will heal. This problem is with the full diagnosis before the intervention.
Sir, also during urethrocytoscopy, we should know the excoriation of the tape, what is used for the TVT, sir. Whether it is present or it visible or not, sir.
No.
Put a dye, put a
It was
contrast.
not visible.
Yes.
Not
You
visible.
can put contrast and dye both and take the picture and see the leakage.
Yes, sir.
You can't put a patient on the standing position while doing the cystoscopy. So you can't see, only see leaks when she stands up.
Even cystoscopy was very difficult in this patient.
Yes.
We done the cystoscopy with a pediatric cystoscope because the beak,
Yeah.
normal cystoscope beak is very long. We cannot see the fistula. We search for long time with a pediatric cystoscope, composite scope, and then we can find this fistula.
So, sir, now we have the diagnosis of urethrovaginal fistula. So, I want to repair this fistula, sir. With the if we have the labial or the vaginal root, actually vaginal roots, sir.
Pardon?
Sir, I want to repair this fistula with the vaginal approach. Hello.
Yes.
Yes.
Vaginal approach
With Mercer's flaps, Mercer's fibropathy flaps, interposition. With the let's go procedure.
but the patient has already undergone TVT previously.
Yes, sir.
So,
Sir, I will during the procedure, sir, I will remove the tape what is present, and we will repair the with the if there is a level skin graft, sir, at that to repair the urethra, and over that we will put the Mercer's flap, sir.
Again, you are complicating the case and the patient. I think she has a small problem right now, and we have to deal with the minimum trouble to the patient. This is can't visible, is not even visible. So you better put the SPC or catheter so that he can, whether it heals automatically or not, a smaller fistula. This is the biggest. And then once it heals, then you go for urodynamic and the radiological studies.
Yes.
By removing the surgical procedure, what he has done, you can getting the mess up there for all that. You don't go to the field where it is already something has been done. There will be fibrosis and everything else. So put a SPC and see that she shouldn't leak for some time, 6 weeks or 4 weeks or 5 weeks, whether this is small fistula heals or not. Better you
Yes.
touch with the laser point so that coagulation, what we call anticholinergics and catheter, SPC catheter, so that it heals. Once it heals, then you go for the investigations and all, urodynamics and all. And you
Yes.
go for the removing the things, making the things worse, you may damage more to this patient than the benefit to this patient. What is the aim? That the minimum intervention, how we can give the relief to this patient by the disease, and then diagnose why this, what are the urodynamic findings and how we can proceed it.
Sure.
If it was wrongly done, we can remove that, but right now don't mess up the things. It's already in a trouble. Please do the simplest thing for it. Okay.
Okay. What are the causes of urethrovaginal fistula?
Sorry, sir.
Causes of urethrovaginal fistula?
Sir, urethrovaginal fistula, there's a more in the developing countries, the obstetric surgery, and in the developed countries, it's more due to the iatrogenic surgeries, like if there is a congenital repair, congenital deformity which has repaired, sir. If there is any sir, like incontinence, anti-incontinence surgery has done, any diverticuloplasty has been done, sir. And other is like, sir, if there is a prolapse like the cystocele, anything is present and operated for that, sir, it can lead to urethrovaginal fistula, sir.
So any question from the students, teachers, or any audience?
There was a question by one machine, I think in chat. Difference between classical and modified O'Connor procedures.
O'Connor. Sir, the classical O'Connor was the bivalving of the bladder, sir. However, in the so modified O'Connor, we are not bivalving the whole bivalving of the bladder, just giving the transverse incision and going up to the fistula, and we will refresh, and then all the already talked, sir, the surgical procedure, sir.
Other chat. No, there is no other question from the, public.
Any question from the students who participated?
Time is over also.
Yes. So thank you for this evening class, online class.
Thank you, sir.
Good night,
Thank you, sir.
everybody.
Good night.
Thank you, everyone.
Thank you, Dr. Singh, sir.
Thank you, thank you.
Thank you. Thank you, Dr. Maiti, for conducting the session in such a wonderful manner.
Thank you.
Okay, good night. Meet you tomorrow 10.
Okay.
10 o'clock. Okay, good night.
Makes sense.